I will welcome everyone to our session. We are extremely excited, humbled, and honored that we have a special session today from the WHO, the World Health Organization Africa, to really discuss which strategies we can look at to prevent and manage sickle cell disease in Africa. This is a very important session, and we have the distinguished Professor Jean-Marie Dangou, all the way from Brazzaville, Congo, to give this talk, and we are just excited, sir, that you're here to join us. And because I want you to have enough time for your presentation, we can go ahead and get started. Those that are attending, I encourage you to use the question and answer box to type your questions so that the professor can address them. Thank you.
Thank you very much, Madam Moderator. Because now that we are all working to
and excuse me, sir, did you want to show your video? I think you were showing it earlier.
It is on.
Okay, maybe it's just my end. Okay, there we go. We can see you now.
Can you see me now?
Yes, we can see you.
Excellent,
yes, sir.
Excellent.
Please continue.
So
thank you.
I was saying that because we are all working to overcome sickle cell disease in Africa, I would like to share this afternoon with you some thoughts around how we can use adapted and best strategies to prevent and control sickle cell disease in an African context. So I think since the beginning of this conference, you have heard several times that sickle cell disease is the most prevalent genetic disorder in the African region. I mean, when I say African region, that means the WHO member states belonging to the African continent. And we in Brazzaville, we are overseeing 47 sub-Saharan African countries along with Algeria. So because sickle cell disease is a major cause of morbidity and mortality in several of our member states, it is clear that the disease is associated with high mortality of babies and children under the age of 5 years. Those who survive the first few years of life suffer recurrent painful crises, infections, anemia, and most of the time, they do have a shortened life expectancy when they get the adult life. In addition to that health burden, sickle cell disease has a major social and economic implication for patients and their families. So sickle cell disease, according to our classification, belongs to the group of non-communicable diseases, those diseases which are not, they are most of the time lifelong diseases, and then they are not passed on from one individual to another. So in that group, sickle cell disease differs to other major SCDs due to its risk factor, which is the inheritance of the sickle hemoglobin gene, making it largely preventable. That's why genetic counseling, mass screening, public awareness, and education play a major role in its prevention. Talking about the global commitment, which started more than a decade ago, and UN agencies as well as the world leaders committed to tackle sickle cell disease. And you can see on this slide, there was an AU, an African Union increased resource mobilization and allocation for the prevention and control of sickle cell disease through multi-sectoral collaboration and action. The second objective is to identify priority interventions for member states to develop and implement policies and programs for sickle cell disease prevention and control at all levels of the health system. And the third objective is to establish mechanisms for monitoring, evaluation, and research on sickle cell disease, particularly in the African context, and apply the findings in policies and programs. Consequently, there is still a list of priority public health interventions to be implemented at country level. So we were expecting all the ministers who endorse the strategy went back home to disseminate and implement the following priority public health intervention. The first one is improving health care provision at all levels of the health system, starting at primary health care up to tertiary, the tertiary level of the health system, including screening of newborns, training of health professionals, and development of protocols for sickle cell disease. The second intervention is offering genetic counseling to all the population, focusing on the people with the sickle cell trait, but also the people suffering from the disease. The third priority intervention we were suggesting countries is improving access to essential medicines and technologies at primary health care level, such as hydroxyurea, penicillin, prophylaxis for infections, lab capacity for diagnosis, and follow-up. The fourth intervention is improving geographical and financial accessibility to healthcare services, particularly for sickle cell disease. The fifth one is raising public awareness in schools, in communities, in health institutions, but also in media and all types of association. Last but not least, we are suggesting establishing patient support groups, which will be doing advocacy and policies on employment of sickle cell disease patients. That were the priority interventions we suggested to the 47 member states. So where are we now? As of 2 years ago, we conducted a quick survey to see what has happened since the adoption of this strategy in 2010. And I will be presenting what we gathered from the countries which responded to our survey. We all know that there is a sickle cell cycle belt in Africa from sub-Saharan Africa through the north of Zambezi, where the prevalence of the disease varies between 10 to 40%. So when we carried out the survey, the respondents gave us these new figures. If you take the prevalence of sickle cell trait in newborns and adults, most of the country, almost 63% of them, have no figure on the prevalence of sickle cell trait in the country. Benin projected the prevalence at birth at 2%. Nigeria gives us the figure of 24.7%, Uganda 13%, Mali 19%, Senegal 10, and Ghana from 9 to 13%, Tanzania around 18%, Ghana 3%, Kenya 3%, Gabon 25%, Niger 23%. Other very interesting figures we gathered are related to the prevalence of the disease at birth. And for that also, the majority of the countries don't know what is the situation. I have listed here 15 countries which said they don't know what is the situation or the disease at birth. Uganda, Congo, Mali, Senegal, Ghana, and Tanzania reported a few figures. And if you take now the prevalence of the disease in adults, here also 14 countries responded that it's unknown. And we got figures from a couple of countries, but here I would like to highlight the figure we got from Mauritania. They said the prevalence of sickle cell disease in adults is around 53%. This is very, very high. Almost half are suffering from the disease. That's quite worrisome. So we try to get the reference for this figure they provided to us, and it was coming from a thesis in 2018 from the University of Nouakchott in Mauritania. When we looked at what is the status of funding in countries for sickle cell disease, we realized that healthcare management, primary prevention, and health promotion were the areas benefiting from funding coming from the government, but also from partners. And the distribution of sources of funding is provided on the graph of this slide. And as you can see, in quite all the countries, the majority of the funding provided to combat sickle cell disease was coming from international partners. With regard to public health infrastructures for sickle cell disease, 6 countries out of the 29 which responded don't have designated units in the Ministry of Health in charge of newborns. And you can see here the list of these 6 countries. But in the majority of countries, there was a unit at the Ministry of Health responsible for newborns, and this unit was in charge of addressing sickle cell disease issue. And when we look at the number of staff, it varies from, it started around 2 to 5 in a couple of countries like Nigeria, Togo, Liberia, Kenya, Burkina Faso, and Zambia, from 6 to 10 in 3 countries, Angola, Tanzania, and Uganda, and more than 11 staff in the unit in 4 countries, Benin, DRC, Democratic Republic of Congo, Mali, and Ghana. We were also interested in knowing if in those countries there were relevant policies, strategies, and action plans for sickle cell disease. And on the right-hand side of this of the slide, you can see the response was quite different. There were 16 countries where sickle cell disease was included in the outcome or outputs of the current national health plan. In 8 countries, the national authorities set time-bound national targets for sickle cell disease. And in 5 countries, there are national indicators of these targets. So you can see that it was not perfectly done in all countries, but it was very encouraging that things were moving in the right direction. In terms of screening and diagnostic methods here, on the left-hand side of this slide, you can see the list of the test methods for the diagnosis and management of sickle cell disease. And as you can see, it was mainly electronic cell counter, which was available at primary, secondary, and tertiary care. The second tests largely available, but a bit less than the electronic cell counter, was the point of care test for sickle cell disease. So it varies a lot from country to country. On the right-hand side, it's important to see the price the patient or the family will have to pay. And most of the time, all those patients and their families are not covered by insurance. So they are experiencing some financial risks because of the disease. We also looked at the situation of newborn screening. And 12 countries responded that they were practicing newborn screening, but it was on a very limited area in the country. This newborn screening was not provided as a national program, except in Mali, in Democratic Republic of Congo, in Uganda, and in Ghana. So we were also interested in knowing if the newborn screening was provided at primary health care, in primary health care facilities. And again, only 4 countries responded yes. It was Niger, Ghana, Mali, and DRC. With regard to the point of care tests for primary screening, Congo, DRC, Guinea, Liberia, and Kenya were where it was done. And for the rest, there was it was some different methods which were used for primary screening and confirmatory tests. It was also interesting to check how sickle cell disease prevention and control was linked to other existing programs, like, for example, the HIV screening program. As you can see on the right-hand side of this slide, most of the time there was no link between the sickle cell disease program and the HIV screening program. The same for the sickle cell disease screening program with maternal and newborn program. Country responded no. So the links were not obvious with other existing programs. In terms of therapy methods, there was quite an interesting access to pneumococcal vaccines, to Haemophilus influenzae B vaccine, but also good access to oral penicillin and to malaria prophylaxis. However, the availability of hydroxyurea was found in 11 countries, but among those 11 countries have a protocol for its management. And as you know, it's very, very important to have a protocol when you are using hydroxyurea in sickle cell disease patients. Concerning the mechanisms for follow-up for diagnosis babies, it was available in very few countries or clinics. And there were 2 types of packages for follow-up. The standard package for follow-up, which is a combination of folic acid with anti-malarial medication and oral penicillin. And the second package which was found was a modified package for follow-up where anti-malarial medication was replaced by insecticide-treated bed nets. As you can see from these slides, there were notable achievements in the region with regard to sickle cell disease prevention and control since the endorsement in 2010 of the WHO regional strategy for sickle cell disease prevention and control in Africa. I have listed here few domains where those important achievements were made. Despite those achievements, we are still facing an important number of challenges. I have grouped those challenges into two main areas. The first one is related to weak governance in our member states, insufficient advocacy, and inadequate financial resources. And this hamper the introduction and scale-up of NCD prevention and control, including at primary health care level, particularly for sickle cell disease. I've said it, there were political commitment at global level, at regional level, but also at country level. But unfortunately, they were not translated to action, either at country or at regional or sub-regional level. And countries are still facing a double, I will say a triple burden of disease. There is a growing demand. There are a lot of unmet and unrecognized needs with low prioritization in all the countries. And this is a big barrier to the implementation of sickle cell disease prevention and control. The inadequate financial resources. If sickle cell disease is not prioritized, that public health problem will never be funded. So in this atmosphere of health system underfunded and not adapted to manage non-communicable diseases at large and sickle cell disease in particular, the inadequate financial resources is really an important challenge. We all know that in sickle cell disease patients, there are some triggers for the occurrence of a crisis. And unfortunately, non-communicable risk factors such as tobacco, unhealthy diet, or harmful use of alcohol are very prevalent. And we are also facing a big interference from the industries manufacturing those risk factors for NCDs. So they are still very common in the region, and this is also a big deal for the management of sickle cell disease in our region. The second group of challenges here on this slide are related to weak service delivery and health information systems in our countries, but also to insufficient skilled personnel. And as you can see here, our health systems, most of the time, are designed for short-term curative care, and they are not able to cope with the impact of non-communicable diseases and sickle cell disease in particular. Few national policies on sickle cell disease without time-bound targets and national indicators, including on genetic counseling, are available. I have shown you a few figures on that a couple of minutes ago. The sickle cell disease interventions are not adequately integrated into primary healthcare services. And that's important. The majority of our population, the first contact with our health system is through the primary healthcare. If sickle cell disease prevention and control is not decentralized at that level, we are missing a very, very important opportunity. We are missing the bulk of our population. In terms of diagnostic technology and life-saving essential NCD medicines, there is a very big shortage. Those technologies, those medicines are not widely available, particularly again at primary healthcare level. There is a limited access to good quality rehabilitative and palliative care services, poor community participation in sickle cell disease prevention and control. I'm very happy today to see all those non-governmental organizations, all the associations working to sensitize, to raise awareness, to advocate for sickle cell disease. Because unfortunately, we are still having cultural and stigmatization of the disease in most parts of the continent. There is no premarital counseling for those with sickle cell trait. And I will end this listing of challenges with the insufficient knowledge on sickle cell disease of health workers, particularly those who are in close contact with the population at primary healthcare level, but also a weak health information system, which is not providing up-to-date information on sickle cell disease. So what should we do? Should we adopt and implement to build forward better? Here is a list of 10 strategies I would like to put forward. First, we should identify and implement specific set of sickle cell disease cost-effective interventions to leapfrog progress towards attainment of SDG 3.4. I have heard a very nice presentation on advocacy, which could be one of these cost-effective interventions. We should include essential sickle cell disease services in primary healthcare. We should expand the benefit packages for universal health coverage to include sickle cell disease. We should also tackle risk factors by implementing at least 3 domestic regulatory or fiscal measures to tackle tobacco use, alcohol, sugar-sweetened beverages. We should secure seats for people living with sickle cell disease at the decision-making tables of international financing mechanisms. We should harvest digital technology to scale up screening, early diagnosis, and self-care of sickle cell disease. We should treat people living with sickle cell disease during humanitarian emergencies. We have seen during the Ebola pandemic what happened to all the people living with sickle cell disease. We should also establish treatment targets for sickle cell disease, similar to those for HIV/AIDS. We should establish meaningful and effective partnerships that contribute to SDG 3.4, and we should strengthen data and surveillance for the prevention and control of sickle cell disease. My last slide is this one. I would like to add to the 10 I suggested, because all the countries are not at the same level in terms of combating sickle cell disease. So we should adapt and adopt based on the context of our country. And so here, I am suggesting again, we obtain national, sub-regional, and regional policy commitments for sickle cell disease. We implement multi-sectoral programs for the prevention and control of sickle cell disease, focusing on primary health care and universal health coverage. We should strengthen lab and diagnosis capacity and provide affordable medicine for sickle cell disease management and pain relief, as well as immunization for all sickle cell disease patient. We should train health professionals. We should integrate national sickle cell program into maternal, child, and adolescent health programs. Very important. We know some of the programs do have financial resources. So let's anchor sickle cell disease program to those programs. We should undertake sickle cell disease surveillance integrated into health management information system and promote our in-house research on sickle cell disease. Last but not least, we should strengthen intersectoral collaboration and partnerships between government, partners, health professionals, parents, patients, relevant community interest groups, NGOs, and the media to address sickle cell disease in Africa. I thank you for your attention.
Thank you so much, sir. That was a wonderful presentation. And I'm just allowing my video to set up. I want to ask the attendees today to please submit questions to the question and answer box. So, sir, you have had several years of experience in this area of non-communicable diseases. What would you say you've seen in other diseases that have been managed more successfully? What was the recipe?
Thank you very much. I think at the start, it will be very, very difficult to manage and overcome all the challenges I listed in my presentation.
Yes, sir.
First thing to do, as I said it, we should anchor sickle cell disease program to other programs which have gained experience at country level, which are well funded, and which have some kind of bridges with sickle cell disease. If you take, for example, child and adolescent health, that's a domain where sickle cell disease has its place. It should be anchored to those kind of programs. Maternal health, the same. Programs like immunization. We know how important immunization is for sickle cell patients. So we should anchor. So my takeaway message today is first to anchor sickle cell disease to existing programs, but to decentralize most of our interventions to the level of the health system where the majority of the population can have access to.
I'm gonna thank you, sir. Thank you so much. And we have a question from Dr. Generette Coretta. Can you speak a little bit about the strategies for the prevention of sickle cell? This is not often talked about in the United States. And I think that's an excellent question because we all say prevention is better than cure. And especially in countries such as those in Africa, we've noticed that we see severe sickle cell disease because they didn't even get the simplest of interventions. So can you please speak to that?
So here, I think we need to distinguish several types of prevention.
Mm-hmm.
Let me start with primary prevention. Is how we can stop the occurrence of the disease in healthy individuals. So here, as this is a genetic disorder, we should start by stopping people who already have the gene in one or another way in their body to get married. And that is not something easy.
Yeah.
And that's where the genetic counseling sits. You should explain how the disease occurs. Let people make informed choices. There is now the secondary prevention, which is mainly related to identifying people with either the trait, either the disease. And this secondary prevention, the primary prevention, but it will also help in preventing the complications of the disease, the morbidity, and the high mortality. So it's not easy for sickle cell disease to a very aggressive promotion of primary prevention because of human rights. It will be difficult to prohibit two people from getting married only because they do have the sickle cell trait. So it's not easy, but if you explain correctly and let the people make an informed choice, an informed, very well-informed decision, I think we can get there.
Thank you for that. And, you know, I was reflecting on the slides that you showed, the introduction slides, and you showed how there is this the plan, the strategies that you were thinking of. And the last one talked about establishing advocacy groups. I don't know if you, yes. So when I was thinking about that, you know, we're here today at the African Congress of Sickle Cell Disease, and there's several advocacy groups for sickle cell disease. Is there a plan to partner with those that already exist? And then for the countries that don't have any, help them establish? Like, is that something that you see being the WHO role, or what would you suggest?
Absolutely, Madam Moderator. One of our role is a convener role. And we started a long time ago. We organized a couple of meetings in which we involve what we call non-state actors.
Okay.
At the beginning, WHO was primarily working with the Ministry of Health and other government departments. But for many years now, we have opened up our collaboration and partnership with all non-state actors. And we have now a framework for engaging with non-state actors. It's clear we can work with all non-state actors as soon as far as they are compliant with what exists in this framework. Moreover, for sickle cell disease, we are working at global level for establishing what we have called till now the Global Sickle Cell Disease Coalition, in which there is WHO, there is the World Bank, there is the US Human and Health Services. We do have some pharma, big pharma. We have a few countries we join officially through the Ministry of Health. We have NGOs, we have academia. There are a lot of participants to this coalition. We are now finalizing a 5-year strategy to overcome, as we said, as the theme of this meeting, sickle cell disease globally. But our primary focus will be Africa, where most of the patients are located. And we are open to all the meetings. That's why we are even co-sponsoring this meeting organized by NGOs.
Yes, thank you.
So that's a testimony of our openness, our willingness to continue working with all state, non-state actors, particularly on advocacy. We should know exactly what are we advocating for.
Yes,
and I
sir.
think it's clear advocacy is one of our focus, as well as sensitization, information, education, communication around sickle cell disease, raising awareness. Over back to you.
Thank you again. So, you know, whenever we have someone with your caliber with us, we start getting bold. You know, we start dreaming big and asking big questions. And, you know, I've always wondered when I look at the World Health Organization, most of us are familiar with the communicable diseases, that impact that you have on really attacking infectious diseases. So do you feel that the non-communicable disease arm, the one that you are maintaining your leadership position in, do you feel that the resources are similar? Are you able to, do you feel like the platform is the same? Or do you feel like there needs to be work in that area to strengthen the non-communicable disease side?
The situation has really improved since 2011, following the first ever global summit on non-communicable diseases organized in New York under the leadership of the United Nations General Assembly. This has culminated on what we called at that time the Political Declaration on Non-Communicable Disease Prevention and Control. And this declaration was targeting 4 main non-communicable diseases. But Africa, during that summit, insisted for sickle cell disease to be part of it. So it main non-communicable diseases, as well as other non-communicable diseases, which include sickle cell disease. And since then, the momentum has been kept high. And in terms of financial resources, what I testify today, flying into preventing and managing non-communicable diseases, I haven't seen it during the time of 2010, 2011. Things are improving, and I'm very optimistic that in the coming years, NCDs will be really well positioned in terms of getting funding to implement the intervention, the activities at country level. I'm really very, very optimistic. Even my program today is, I'm not fully financed, but the level of financing I'm receiving to implement my biannual plan of action has increased. So it's really a good thing, and we are very, very optimistic. Even in countries, we have seen several countries now providing budget lines for non-communicable diseases. So let's continue our advocacy. Let's continue raising awareness. Let's put all our hands together, and I think the success will come very soon.
Thank you, sir. And I think I'm going to take one final question. I see now the question answer box is popping, but this is about accountability. You know, the WHO has a position of power and respect. How do you feel like you can hold the various nations accountable? And one of our members asked, one of the participants asked, how do we begin at the nation level and the continent level? What is the WHO role in accountability for some of these measures?
Accountability is at different levels. It starts first, if you talk about WHO, with accountability among WHO itself. For that, no problem. We have put in place some very stringent mechanisms to ensure we as WHO are accountable for everything we are doing, including the use of financial resources given to us. Accountability is also on the part of the governments. We are the secretariat of the governments. Our primary role is to provide advice and recommendation to them. And one of our main recommendations is to remain accountable, again, for everything. The health of your people is in your hands. So it's mandatory to you to improve their health, to avoid them getting sick, and when they are sick, to provide them with good management of the disease. So that's our role. But as a secretariat, we cannot make the police when it comes to government. But it's not only on the side of WHO and the government. It's also on the side of non-state actors. When you receive funding or when you commit to do X, Y, Z, you should remain accountable for it. So accountability is everywhere. We should all put in our behaviors accountability at a high position. I would like to close on this issue of accountability. We should have watchdogs in all countries. Mm-hmm. Parliamentarians can do it, but also associations, NGOs, the media, what we call in French, le contre-pouvoir, those who can speak aloud, those who can watch and say the truth. It should exist everywhere. Don't count only on WHO to do this part of the job. We can do it all together. Back to you, Madam Moderator.
Oh, Professor Dangou, thank you so much. I have been inspired. And I don't know if we can ask for your generosity. There are some questions in the question and Q&A box. If you stop sharing your screen, you'll see Q&A on the bottom. If you have the ability to respond by typing the answer, I think the attendees will appreciate that. The main two questions came from the side of lab testing and diagnostic capability. And then the other one was about medication, some of the newer medications. What is the role of WHO in that? So if you're able to type the answer, we would appreciate it. For the attendees, the next session is community engagement, which starts in about 4 minutes. So we have a little bit of time if you want to head over there or if you want to stay and see Professor Dangou's answers. But this has been an absolute privilege, a highest honor to have someone of your caliber address us today. We have learned so much from you, and your wisdom and diplomacy is just impressive. And thank you again for your time. I will ask our Congress leads, Ambassador Eddie, to maybe leave the session in a little bit so that he can respond to the question.
I will do it right away. Thank you very, very much. I really appreciate it. You have been a great moderator, and I also thank all the participants for keeping with us during this presentation and discussions. Thank you very much.
Yes, sir. Thank you. Okay, and let me know if you need any assistance with,
Okay, thank you.
are you able to see the questions?
Yes, I've seen them. I'm
Okay.
responding immediately.
Wonderful.
Rightly.
All right,
Wonderful.
thank you. Thank you very much, Professor Dangou. It was really an interesting session with you. A lot of the advice and recommendations was perfect for the audiences to know. We would head to the next session, which is community engagement. And yeah, if you have any questions, rightly as Titi Lopez said, the moderator, you can put that in the Q&A session. We're very certain that Professor Dangou would be glad to answer those questions. So we'll be leaving in a few minutes to head into the community engagement while we relax for other sessions that will be coming up. Thank you.